Hello, everyone, and welcome to our second lecture on depressants and inhalants. So last time we started looking at depressant drugs. We asked what they are, and of course, the definition of a depressant is something that decreases the level of activity in the nervous system. So sort of the opposite of a stimulant. We also talked about the history of depressants. So other than alcohol, which we'll talk about in another unit, and marijuana, which is arguably not a depressant, which we'll also talk about in another unit, all the depressants are really synthetic, almost all. Um, and so we're talking about the history of depressants really from the mid-1800s onward. There are a couple we'll mention today that were developed earlier, um, but depressants are unified by the effects they have on the brain and on behavior. And these are things like decreasing anxiety, decreasing motor movement, which helps for things like seizure disorders such as epilepsy, increasing how easy it is to go to sleep. And so these are all short-term effects. There are long-term effects as well. People can become dependent on them. You can overdose on them, especially things like barbiturates. Um, but they all have this unified purpose, and that is to decrease anxiety, induce sleep, decrease movement. There are also inhalants, and that's what we'll talk about today at the end of this session. The inhalants are sort of a class unto themselves, and why that is we'll talk about then. So in particular, we'll learn about gamma hydroxybutyric acid, or GHB. We'll understand, once we finish talking about GHB, why so many depressants disrupt memory formation. It's certainly true of alcohol, it's true of GHB, it's true of a lot of depressants, and we'll understand why that is, or why we think that is, given our current level of understanding of the nervous system. And then finally, we'll learn about inhalants. Why are they grouped with the depressants? Well, they generally have depressant effects, so we've grouped them here. First, last week's discussion questions. So there was a question about a historical event, which was the use of amphetamines on both sides of World War II. So amphetamines were used both to promote wakefulness, but also as a mood stabilizer. And so the question was, what are the ethical ramifications of that? What if there is a group of people that are in a life-threatening occupation, for example, and there's a drug that can help them survive? How do we consider that drug? Should we administer it? Should we not? How do we deal with that situation? And we want to obviously help people to survive, but these drugs also have other consequences. And so one thing that was brought up was considering long-term versus short-term considerations. So short-term helps you survive, keeps you awake, but of course they can have long-term negative consequences. So how do we weigh those two? And of course the freedom of the individual to choose was frequently brought up. So we shouldn't, the idea that we shouldn't impose drugs on an individual that doesn't want to use them, regardless of what profession they're in. There was also an interesting point about the individual, not just the rights of the individual, but also how do we consider the effects that drugs have on each individual? Do we customize the dosage or the type of drug that's used? And of course, in World War II, amphetamines were relatively new, so this wasn't something that was done. But to what degree is it reasonable, feasible, useful to customize the drug and the dosage to the individual using them? And that may maximize their survival, at the very least minimize the risk of dependence or the other negative side effects that might occur. Next was a fun one. What if a pill could make you smarter? So this has been an issue that was raised when amphetamines were first prescribed for attention deficit disorder or attention deficit with hyperactivity disorder in order to help people focus. And the idea was, well, if it can help someone with a disorder perform normally, could it help a normal person perform exceptionally? And of course, so far we don't have such a drug. Um, but it's possible. It's not outside the realm of possibility that such a drug could eventually be developed. So what if this drug existed? So one point that was brought up by one group was perhaps we shouldn't spend as much time trying to develop or worry about prescribing drugs to fix a behavioral issue, rather than focusing on the environment that perhaps produced the behavioral issue in the first place. That if we can fix the environment, then maybe these drugs won't be necessary. So that's a good point. Um, Certainly, there are a range of environments in which people are raised and which people inhabit, and they can affect our psychological development. They can certainly, something as simple as nutrition can affect how well we're able to focus. So with your midterm exam coming up, be sure to get plenty of rest and also eat well, because those are two environmental factors that can affect performance. Don't resort to amphetamines. There's also a big issue of fairness. This gets brought up whenever you bring up the concept of a smart pill. So drugs usually start off, even if they don't remain, pretty expensive. Many times they remain expensive as well, even after they've been on the market for a while. But imagine a smart pill that was very expensive and only the wealthy could afford it. Well, now you're at risk for developing not only an income gap, but now an intelligence gap, effectively speaking. Not inherently, but because of the use of the smart pill, people are now have more resources, but also have access to better cognition. So there are issues of fairness involved, and to what degree would that uh, induce disparities in the marketplace for things like jobs, for things like getting into school, for performance at school? So how would you feel if you were trying to get into college and you were competing with a bunch of kids that had these cognitive enhancers? Um, so it's a non-trivial issue. There are also, of course, considerations of side effects, and this is true for any drug, but if we're talking about a drug that everyone will be using, the side effects become particularly important, especially if they're long-term side effects that aren't obvious when everyone starts taking them. If you have a population where everyone's taking this drug, and it turns out after 10 years it makes you sterile, now you're in big trouble. Um, so, as always, side effects are important to consider, but especially for a drug that promises to become very popular, you have to become that much more vigilant about long-term side effects. The final one was current laws on cocaine. Uh, so current, laws on cocaine, especially there's a disparity between severity of penalties for crack cocaine and powdered cocaine. And we talked about that last week. But uh, overall, are these laws too severe, not severe enough? Um, and so one thing to consider, of course, is not just, oh, we're getting these drug users off the street by penalizing them. What are the consequences of that sort of regulation? So by increasing the prison population, for example, you have obviously a decrease in the amount of accessible workforce, but you've also got a population of people that you have to pay to maintain, um, which is not to say that drug use isn't associated with crime and that crime shouldn't be punished, but there are more considerations at hand than just the moral implications of drug use itself. When this was brought up in discussion. Of course, one interesting question that was posed was, what if the laws change, especially in the direction of more severity, and you're already addicted? Is that reasonable? Is that fair? Now perhaps it was in your control to start using the drug in the first place, but whenever we make a decision, we always consider the consequences. And now, by changing the severity of a penalty, now you sort of, in a certain way, invalidated that original decision, even if the outcome wasn't good, or even if the outcome wasn't well considered in terms of consequences. You've now altered the playing field. And so, what do you do for people that are already addicted, and suddenly you make the penalty more severe on them? Okay, so as always, good discussion. We will stick with the current discussion groups moving into the next week, and then I will remix the groups. So keep the discussion groups for this week, and then I will change them. And I will post an announcement about that when that happens. Okay, so getting back to depressants, the first one I'll talk about is gamma hydroxybutyric acid, also known as GHB. It was first synthesized in the 1870s, but its psychological effects weren't really appreciated then. It was more of a chemical experiment. But it was started to be studied in the 1960s because it binds to the GABA B receptor, the metabotropic GABA receptor that we mentioned last time. And so lots of drugs, and this is true for drugs as well as toxins, are used in neuroscience research because they affect a particular receptor or class of receptors. And so you can see how a neuron functions, if it does, once a particular kind of receptor, a particular kind of ion channel has been knocked out or has been enhanced. So in the 1960s, GHB was starting to be studied because of its effect on neurons. GHB, as I said at the beginning of last session, the depressants we'll talk about for the most part are synthetic. But GHB actually occurs naturally. Our bodies produce it in small quantities. Now for the drug, it's synthesized, but of course, chemically they're identical. The drug produced synthetically is the same as the substance that's produced by our bodies. It just happens that it's produced in larger quantities, and so it's not efficient to try and harvest it from a natural source. But anyway, GHB is a depressant that does occur naturally. So what is GHB used for? Well, it has effects that are similar to alcohol, so we can sort of expect that it would have similar behavioral effects, and if people are looking for alleviation of symptoms, it's possible they could turn to GHB. But legitimately, the only real treatment currently in the U.S. is for narcolepsy, which is a sleeping disorder. And it may seem counterintuitive that a disorder where you fall asleep frequently, and when falling asleep isn't under your control, that those symptoms would be alleviated by GHB, which is a depressant, but nevertheless, it seems to help. So that is the only currently recognized use in the U.S. of GHB. It's, of course, more famously used as a date rape drug like Rohypnol, colloquially known as rupees. So this is a substance that lowers inhibitions, also in sufficient quantities, sedates the person, makes them unable to resist an attacker, but also disrupts memory of the attack. Now, this is a common problem. It's true for alcohol as well. It's true for many depressants, and we'll talk about that in the next slide. So because GHB is dangerous in certain circumstances and used illegally, but also as this sort of one legitimate use, the narcolepsy preparation, even though it's still GHB, is listed on Schedule 3, whereas GHB just by itself, not in the solution used to treat narcolepsy, is listed on Schedule 1. So you have this interesting dichotomy in how GHB is treated. And that will bear on our discussion this week as well. So switching gears a little bit, why do depressants disrupt memory? Well, it's a very common symptom, especially for high doses of depressants. So talking about memory, memory is the result of learning. So whenever you're talking about the psychology of memory, you can't talk about memory without talking about learning. Learning is the process, and then memory is the product. So a memory is a set of information that can be recalled. And it comes in a lot of forms. I'm not going to belabor the different kinds of memory that exist. That's a topic that's usually covered in Psych 101 or biopsychology. So we're not going to worry about the different forms, but the form that matters for our purposes today is what's called long-term memory. And of course, memories are stored in the brain. So information, especially associations between different kinds of information or different events, is stored in the brain, eventually using long-term memory. So at first everything is what's called working or short-term memory, and then after a while that information is repeated, or if we're trying to remember it, if we're trying to store the information for later, it gets put into long-term memory. And so on the right here, we see a famous example of memory, a certain kind of memory, and this is Pavlov and Pavlov's dog. And what Pavlov did was train a dog to associate the ringing of a bell with getting food. And this is what's called classical conditioning. Again, we're not going to go into the details, but the idea is the dog learned to associate a bell ringing with the idea that food was coming soon, and so it would start to salivate. Um, but this is an association the dog didn't have before. Didn't have any reason to, but it learned that first comes the bell, then comes food. And so that was laid down somewhere in its brain. And our brains are no different. We still store memories in our neurons. So this brings up the idea of what's called Hebbian learning. Hebbian is named after Donald Hebb, who was a famous neuroscientist. But this idea is usually summarized as neurons that fire together, wire together. Which means that if the presynaptic neuron fires, and the postsynaptic one fires as a result, that the more often those have happened together, the stronger that association becomes. And the more easily the postsynaptic neuron will fire when the presynaptic one does. We recall from our unit on drugs in the brain that neurons sort of add together all the impulses that are coming in from presynaptic neurons. And so if the neuron reaches a certain threshold, it'll fire. And what Hebbian learning says is, well, for presynaptic neurons that are associated with the postsynaptic one firing, the postsynaptic neuron will actually become more sensitive to those presynaptic neurons. It'll fire more easily. And it's thought that's what underlies memory. And specifically, it's thought that a process called long-term potentiation, which usually is called LTP for short, is what underlies memory. Now, so the idea here again is that when a neuron that responds to a stimulus fires, if the neuron that's responsible for the response, in a simple case, also fires, then those become associated. And the responding neuron, the second neuron, will fire more easily as it learns to associate responding with a particular stimulus as represented by that first neuron. So here we have an example of LTP. Again, not going to go into the details neurologically, but the idea is that memory, the formation of memory in the brain, depends on activity in the brain, depends on patterns of activity. So if you use depressants to decrease the level of activity in the brain, it's going to be less likely that those neurons fire together. So you no longer have that correlation between one neuron and the other. You're not going to get those synapses strengthened. That postsynaptic neuron has no reason to become sensitive to the presynaptic one because they're not firing together anymore. You've decreased the level of activity in the nervous system. And so you don't get that memory formation. You don't get that association between neuron 1 and neuron 2. And so it's thought that's why depressants disrupt memories. They decrease the activity level in the brain, so they decrease the likelihood that neurons will fire together and form memories, form associations between neurons. Okay, so moving on to the final class of depressants we'll consider, and those are inhalants. And these are an unusual group because inhalants are, as the name implies, defined by their method of administration, that is how they get into the body, rather than the effects they have. Inhalants are actually very structurally different from one another. So chemically, they don't have much in common. They generally have depressant effects, which is why they're grouped with the depressants for our purposes. But they're grouped together mainly because they're all inhaled. They're all taken the same way, which is a little unusual, again, because imagine if we classified the opioids and cocaine all in one group because they're sometimes injected. So that wouldn't make much sense. It also wouldn't make much sense to put alcohol in the same category as anything else just because it happens to be consumed orally. So psychotherapeutic drugs, amphetamines, and alcohol, even though they're all ingested, don't belong in the same group. But the inhalants are, so we'll go with it. One of the earliest inhalants were the gaseous anesthetics. These became more commonly used in the 1800s. They were technically synthesized in the late 1700s, but they became more commonly used in the 1800s as anesthetics, as agents that would induce unconsciousness, especially for surgery. One of the earliest and most famous is nitrous oxide, which is laughing gas. You probably encountered it at the dentist, or if you've had surgery, oftentimes you'll get laughing gas first and then get a more potent, long-lasting anesthetic. Here on the right, I have a diagram. Here, what nitrous oxide means, it's the one in the middle, N2O. The one on the left, NO, is nitric oxide, and it's actually produced naturally by your body and is used commonly in synaptic transmission. Nitrous oxide, the one in the middle, has 2 nitrogens, 1 oxygen. And then the one on the right is nitrogen dioxide, which is not good for you. So these small changes, adding a nitrogen, having an oxygen instead of a nitrogen, these make big differences. Anyway, so nitrous oxide was one of the first gaseous anesthetics, but it takes a lot to induce unconsciousness, and that's dangerous. And so it was not a very effective anesthetic for long surgeries. You also have diethyl ether, which is often just referred to as ether. And this was another common anesthetic. But again, it's very difficult to get the amount right, which is to say that anesthetics have a very narrow therapeutic range. That's why you have a whole class of doctors called anesthesiologists. A lot of factors come into consideration regarding the individual, regarding the anesthetic being used, and we still don't have a great take on why anesthetics have the effect they do. They're one of the most mysterious classes of drugs in terms of how they have their effects. We just know that they tend to put people to sleep. But they can be very dangerous, and so that's why we have specialists that work with anesthetics. After that came the nitrites, not the nitrates, the nitrites. We're not going to get into the chemical difference, but some of the most famous are amyl nitrite and nitroglycerin, which is a famous explosive, but also it's famous for treating heart conditions. So on TV, if you've ever seen someone go through chest pain and then try to find their pills and then put a pill under their tongue, usually that's a nitroglycerin. So what do these substances do? Well, they're vasodilators, which means they expand blood vessels in addition to their other depressant effects. Originally, this was used for chest pain like angina. Angina results from when coronary arteries aren't allowing enough blood through, and so this expands those arteries and lets more blood flow occur. So these nitrites were originally used for that. Later on, they became used recreationally. These tend to have very short-term effects, but they tend to induce a kind of euphoria, and they're also, by some people, thought to enhance sexual pleasure. So recreationally, that's the context they're used in. So that is the nitrites originally, and then of course nitroglycerin is still prescribed, but they have both a legitimate medical use and a recreational use. Gaseous anesthetics aren't abused as often, mainly because it's more difficult to administer, it's more dangerous, and it's more difficult to obtain. Gases aren't easy to transport, whereas liquids and pills are easy. Finally, we have the volatile solvents. And so here's a table from your book looking at the various inhalants and what the ingredients are. And this highlights the idea that the inhalants belong to a lot of different chemical groups. Structurally, they're very different, which is one of the reasons why it's sort of mysterious how they have the effects they do. Volatile solvents, of course, are products that aren't intended for any sort of use as a drug. The nitrites are, the anesthetics are, those are intended for human use. Um, the volatile solvents are just household chemicals that can be inhaled. Oftentimes these are aerosol cans or things like gasoline, turpentine, paint thinner, uh, and drugs often have their pros and cons, but when it comes to the volatile solvents, this is really one of the most dangerous forms of drug use. Um, it tends to have long-term toxic effects on the brain, kills brain cells. Also, because these substances aren't manufactured for human use, they're not created in the proper dosages for human use. Um, so people are not only administering these drugs to themselves, they're also deciding on their own dosage, whereas taking a pill, for example, or pouring yourself a drink, um, these are sort of, it's commonly known, commonly manufactured in the appropriate dosage. Uh, the volatile solvents tend to recruit younger users. Because these solvents are depressants, they tend to have a lot of the same effects as alcohol. They're intoxicants. But if you're old enough, you can just buy alcohol. You don't have to buy these inhalants. Um, but if you're younger, if you cannot legally obtain alcohol, people often turn to volatile solvents because these products are so widely available. These are household chemicals, for example. Um, and so this tends to recruit a younger user, which is unfortunate because, again, they're dangerous substances. One of the most famous examples was in the 50s and the so-called epidemic of glue sniffing. That actually, the original story was from Pueblo in Colorado here. So this was a story that got picked up in the media and exaggerated. And we had a discussion question about this a few weeks ago about how the media treats drug use. It might have done more harm than good because it was an isolated community, and now it's this widespread story, and now you wonder if people will start using this inhalant just because of the news story. Um, but that is perhaps the most famous example of inhalant use, even though it wasn't all that prevalent to begin with. Okay, so that will wrap up our unit on depressants and inhalants. Next time we'll look at psychotherapeutic drugs. So this will be next week. So how do we classify different psychological disorders? Different drugs are used for different disorders. So how do we match those up? What properties do the drugs have? What effects do they have on the brain and behavior? And what are the consequences of drug use of this sort? So we will talk about that next week, and I will see you then.